Welcome to Therapeutics. In this block, we're going to review rheumatoid arthritis and osteoarthritis and look at the differences among our treatment options. Primarily, we think of osteoarthritis. Most of what we do for osteoarthritis is just pain management. And the only disease-modifying drugs per se for osteoarthritis might be perhaps glucosamine sulfate, as opposed to rheumatoid arthritis, where our focus is not only pain management, but doing what we can to really use the disease-modifying agents as well. We'll also in this block talk about gout, factors that affect gout, and our management and then prevention of gout. We'll spend a little time talking about multiple sclerosis and fibromyalgia and explain some of the treatment options that are available there. We'll also talk about the osteopenias, where there is bone loss of some type, and differentiate osteoporosis from osteomalacia and talk about some of the treatment options that we have there. And finally, we'll spend a little time talking about osteomyelitis, which is often a complication of diabetic foot infection, but has other etiologies as well. Let's think about osteoarthritis first. We think of osteoarthritis probably as the most prevalent form of arthritis. It affects up to 50 million Americans. It's highly correlated with age, and we consider it really the wear and tear joint issue. Most often we'll see the joints affected in osteoarthritis usually are the knees or the hips, perhaps the lower spine as well. And it can affect women maybe more than men, but that might be a function that women live longer than men, and as such, older individuals are more likely to have osteoarthritis than younger ones. Risk factors, epidemiologic risk factors include obesity, and that extra weight is extra wear and tear and stress on joints. There also may be a genetic or family history factor component associated with it, typically associated with loss of cartilage. There can be some subchondral bone damage associated with it, as well as joint space narrowing. And the symptoms of pain really vary based on patients, but there are often nociceptive nerve endings within the damaged joint that are implicated as well. As we think about our therapeutic goals in osteoarthritis, we're looking both to relieve pain, but also to maintain functional status, improve joint function, prevent future loss of function, and improve or maintain or improve quality of life for patients. And part of the issues we think of is, and I think if you've been in practice or when you get in practice, or this might even just be an observation that you will have in life in general, is that the older patients who live a more full, complete, and less disease-ridden life are often those patients who can move a lot, who spend a lot of time, they walk every day or they have an exercise regimen. And so the ability of patients to get good control of osteoarthritis pain and pain associated with it is going to be an important component in achieving a larger, healthier status overall by allowing them to participate in at least some reasonable exercise. So it's helpful first as our non-pharmacologic approaches to osteoarthritis to make sure patients understand what the nature of osteoarthritis is and how weight loss in particular for folks who are overweight will contribute to reduced load and damage to those joints. We also can look at whether or not they are candidates for physical or occupational therapy, if they are employed in a job that requires them to utilize joints and that osteoarthritis interferes with that. Perhaps there can be some occupational or physical therapy assessment that improves their ability to continue to function in that job. And also looking at moderate exercise and ultimately, in many cases, surgery. Usually we think of in these cases as knee replacement surgery is probably the most common one that we'll see for folks who have serious osteoarthritis. But what we would really like to do is to earlier on identify osteoarthritis and reduce the risk and the potential for someone actually needing knee replacement surgery, for example. The drug therapies we have are pretty standard therapies we use in many other pain or inflammatory states. Our first drugs of choice in osteoarthritis are acetaminophen, for at least for the treatment of pain. It doesn't do much necessarily for the management of ongoing inflammation or preventing further damage, only to the extent that the pain or analgesic effect allows people to continue moving and allowing an exercise regimen. And typically the old regimens were a gram 4 times a day of acetaminophen, and that now exceeds what the FDA really recommends, is not exceeding 2,600 milligrams a day. You also want to make sure that folks are aware of the concerns associated with elevated acetaminophen dosing, and also the concerns as it relates to other products that they may be taking that affect that. Nonsteroidals are a consideration. Here's a risk we have, though. In older individuals, we're always concerned about the risk for kidney injury and for GI bleeding. And in patients who have osteoarthritis, we're often looking at them being maintained on regularly scheduled analgesic. And nonsteroidals, chronic use of nonsteroidal anti-inflammatory drugs really pose a risk for many patients, at both renal risk and a GI bleed risk. And so we need to weigh the risk and the benefit of that. And so as such, this is not a first-line therapy, and many organizations don't recommend anything other than the PRN occasional use of nonsteroidals in patients who have osteoarthritis. If you're going to consider an NSAID, then at least from the GI bleed risk, the COX-2 inhibitor, celecoxib, for example, may have an advantage, but that won't do anything to reduce the risk associated with renal risk or renal injury associated with the use of even a COX-2 specific inhibitor. We're also worried about using any of these NSAIDs in patients who have other risk factors for renal insufficiency associated with NSAID use. That would include ACE or ARB use, that would include diuretic use, dehydration status, or patients who might be on other therapies that could be at least relatively contraindicated using an NSAID. That might be, for example, a patient who might be on lithium therapy. The opioids, finally, were considered. So other adjuvant therapy we'll look at, and there are a number of them. One is gabapentin if there's a neuropathic component, which sometimes there is. Typically, if it's a spinal osteoarthritis, it's probably more likely the case than in other types of osteoarthritis. You'd want to look at avoiding the nonsteroidals in older folks, particularly because of the anticholinergic properties if you can. The skeletal muscle relaxants probably don't offer all that much benefit. And there's some limited efficacy for some of the topical agents, but you're looking at everything you can do to sort of manage that. And they're sort of lower risk agents, even if their efficacy may be spotty at best. There is actually reasonably good data for glucosamine sulfate with or without chondroitin. And I will say that the evidence is reasonable here. It probably is not associated with a lot of risk, except if a patient has a shellfish allergy. But short of that, glucosamine sulfate, and not the hydrochloric salt, just the sulfate salt, has been correlated with some efficacy long-term in patients who have osteoarthritis. And I'll tell you from personal experience that I found that glucosamine really, for patients who have osteoarthritis long-term, offers some benefit at really replenishing some of the cartilage damage that could be involved in osteoarthritis. The data in a number of studies indicate that there is probably little harm and probably long-term benefit. So it's one of the few things, I think, for folks who have osteoarthritis where there's at least some data to suggest it's something positive we're doing to forestall worsening osteoarthritis. But probably reasonable exercise and weight loss is the best thing patients can do. All right, let's switch gears now to rheumatoid arthritis. And rheumatoid, a much more serious condition, systemic disease with bilateral inflammatory state. Usually we see the inflammation in small joints of the hand, the wrist, and the feet. Prevalence is considerably lower than an osteoarthritis. Women much more affected than men. Can occur in any age, and it has an autoimmune and genetic predisposition to it. The inflammation, the chronic inflammation of the synovium leads to proliferation and development of pannus, and that basically affects the joint cartilage, eventually erosion to the bone. Really pretty destructive kind of process that happens here. And patients will often present with pretty severe symptoms of joint pain, stiffness, fatigue, and they'll often have other markers of severe inflammation, including warmth, redness, and swelling of the joints. Typically, you're going to do a laboratory test looking at rheumatoid factors. You're probably going to send them to a rheumatologist for an evaluation. And keep in mind that there can be extra outside of the joint manifestations in rheumatoid arthritis as well. The treatment goals in rheumatoid arthritis are to control the inflammatory process so that patients can actually go into remission. We're hoping to relieve pain for patients, reducing the number of joints that are affected, improving their pain, decreasing their stiffness, particularly in the morning. And we'll look as part of our process of how well folks are doing. In addition to the functional status and their symptoms, we'll also look at serologic markers such as rheumatoid factors. But ultimately, improving their quality of life is a real goal we have for patients with rheumatoid arthritis. Really key in rheumatoid arthritis, and what's been really the situation in the last decade to 2 decades, is really early implementation of disease-modifying anti-rheumatic drug therapy. And these therapies usually are started early on. And if you're working in primary care or hospitalist care or some other area, you're going to refer this patient to a rheumatologist early on. These disease-modifying drugs are really under the purview of the rheumatologist. They're not really managed. We don't usually find that primary care providers manage these. But it's definitely important that you as a clinician know that these patients are on these disease-modifying agents. The standard older disease-modifying drugs, the non-biologics, include methotrexate, hydroxychloroquine, sulfasalazine, are really the three I think we see the most often used as the older agents. And then the biologic agents, typically they are the same agents, or many of the same agents we saw in using in the use of Crohn's disease and ulcerative colitis, that we saw in the use of certain severe psoriasis as well. And these drugs inhibit tumor necrosis factor or interleukin receptors, and they are really appropriate for folks who don't really tolerate methotrexate or hydroxychloroquine. Typically what you'll expect is that for patients who are on one of these agents, either an older agent or a biologic, that you expect about 3 months before you begin to see some real meaningful benefit. But what you'll often see is that I think most clinicians would consider methotrexate as a first-line agent if the patient doesn't have some problems correlated with its use. But then if methotrexate isn't all that effective, or if there's some reason why there's a hesitancy to use methotrexate in a patient, then we're going to see patients swiftly change over to one of the biologic agents. So let's look first at methotrexate. And methotrexate in higher doses is also used in oncology. But in lower doses, we use it in rheumatic disease, and it's still considered one of the first-line agents. I think you may see some evolving over time that methotrexate by some rheumatologists we look at patients who might be a little more limited in using methotrexate and would go to a biologic before methotrexate. I'm going to defer that discussion to what's evolving in rheumatology fields. When you see methotrexate used, the toxicities include hepatic fibrosis. Bone marrow suppression is a real concern for us. Also a risk for GI bleed and pneumonitis. Folks need periodic liver function tests and kidney function evaluation done. And typically what we see is a once-a-week dose. And typically patients will be on an oral therapy, start maybe 5 milligrams once a week, I don't know if it's convention, but every patient I've seen in the hospital over the last decade who comes in on methotrexate, typically they're ordered on a Monday for some reason. Maybe that's just the rheumatologist's patterns that we see in our particular region. But you'll see it ordered once a week. And so if you're doing med reconciliation, this may be a drug that patients may be on that patients may forget they're on because they're not on it every day. And so if they're not on a drug every day, they sometimes forget that they're on it. We also have hydroxychloroquine, or Plaquenil. This is used still fairly frequently. I don't see a lot of patients come in the hospital on it, but every so often we do. And again, like we saw with methotrexate, it's a drug that, or other biologics for that matter, it's a period of at least 3 months before we begin to see some benefit from it. The concern with hydroxychloroquine, and this comes more from its use as an antimalarial drug than it is from its historically identified from its use as an agent for rheumatoid arthritis, is that it's a potential for retinal damage that can be irreversible. So that gets people a little concerned about hydroxychloroquine use. And then looking at the biologics, and there are many of them that can be used. There are oral now available as well as parenteral agents. The classic agent I think we think of for severe rheumatoid arthritis as a biologic is Enbrel or Intercept, which is for moderate to severe rheumatoid, it inactivating tumor necrosis factor. It's actually been on the market for a decade or so. It suppresses inflammation. It's used in rheumatoid arthritis, and it is injection site reactions are possible. We're always concerned about immunosuppression with these drugs, and so because of that, you want to be careful of comorbid infections. You also want to look at avoiding live vaccines for patients. The other similar drugs that fall into this group are Remicade, Humira, and Orencia, and those three are used pretty frequently as well in patients with rheumatoid arthritis. Probably of all of the concerns we have for the biologic agents, particularly the anti-TNF, but really for any of the biologic agents we use here in these autoimmune conditions, is their immunosuppression, and the immunosuppression that poses risks for lots of problems, not least of which are serious infection risks. And so these agents are always considered contraindicated in patients who have serious infections already. We also need to make sure that we rule out tuberculosis. We want to sort of look and see whether they have Hep B, Hep C, if they're HIV positive, anything that is a serious infection risk, because these agents are going to suppress immunity. In addition to infection risk, we also worry about the suppression of immune status that might perhaps increase their risk for things like lymphomas. So cancers and lymphomas particularly are more likely to occur in patients who are also immunosuppressed. All right, let's look at a couple of the other ancillary treatments here in rheumatoid arthritis. One of them is sulfasalazine, and it's not really officially approved for rheumatoid. More, it's used as an older agent in inflammatory bowel disease, but might offer some benefit. And occasionally we'll see rheumatologists who add this on to a regimen for a patient with rheumatoid arthritis, particularly if it's early on or milder situation where they're trying to forestall the use of a biologic in a patient. What used to be used pretty frequently and is less frequently used now, but I'll mention here because I think they still are available and sometimes used, are the gold salts in patients who have rheumatoid arthritis. And there's some reasonable data that they really have worked to relieve pain and stiffness in about 2/3 of patients, with about 15% of patients actually experiencing a remission. But a fair number of patients also have serious adverse effects associated with it, including serious rashes, nephrotoxicity, or blood dyscrasias, liver injury, and the like. And so they're available, gold salts, as both IM and oral. I think they're less frequently used now by rheumatologists, but you probably need to be aware of some of these agents, and there are certain patients who might still be on them. Some of the other drugs that are listed here are really second-line agents in management of rheumatoid arthritis, but you may see patients on them. And really, the bottom two, the two I want to focus on: cyclosporin, immunosuppressant, and more often we see cyclosporin in patients who are we think of transplant medicine, but it's immunosuppressant, and as such, it may have a role in rheumatoid arthritis. And interestingly, of all of the antimicrobials, minocycline, which is a tetracycline derivative, actually has some benefit, modest probably, but some benefit in patients with rheumatoid arthritis. And so occasionally you'll see that, as bizarre as that may seem or sound. As azathioprine, an older agent that is occasionally used as well, and Prosorba used with plasmapheresis, and I have to tell you quite honestly, I have no experience with that agent. The other things that are sometimes used in rheumatoid arthritis are not disease-modifying therapies, but are analgesics and or anti-inflammatories, and sometimes you'll see nonsteroidals. And in the old days, before the age of the biologics, we also commonly saw patients with rheumatoid arthritis on chronic corticosteroids. But truth be told, that it's pretty infrequent now to see folks on chronic corticosteroids for rheumatoid arthritis. The age of the biologic agents has pretty much eliminated the need to rely on long-term corticosteroids. Occasionally, though, you may have somebody for whom short-term, to get better control short-term, they may be on a nonsteroidal, and maybe a pulsary period of time where they're considered on a corticosteroid. I would say for the most part with rheumatoid arthritis, because you're always concerned about the long-term use of NSAIDs and the long-term use of corticosteroids, you really ought to have the discussion with the rheumatology team about how to best manage that in any circumstance other than a very short period of use of these agents until they get seen by the rheumatologist again. And then the non-pharmacologic treatments in rheumatoid arthritis are really looking at periods of rest, particularly during disease exacerbation. They probably are good candidates for occupational and physical therapy, supporting mobility, maintaining function. And like we saw with osteoarthritis, important also to avoid overweight and obesity, which has, again, significant biomechanical stress on joints. All right, here are a few slides that are tables that will list some of the common agents that you'll see used in rheumatoid arthritis. First, we have some of the non-biologics, particularly methotrexate, hydroxychloroquine, sulfasalazine, and then the biologics. First, the TNF inhibitors listed here, and Taracept and Infliximab as examples there. And then the non-TNF biologics as well that inhibit other modalities, maybe interleukin-1 or the inhibition of interactions between antigens and T cells, or interleukin-6. So you'll see that each of these agents sort of have a particular role. And finally, there is a kinase inhibitor. Really, the advantage of this agent, Xeljanz, is that it's oral. And so it's different. It can be used as combination with methotrexate or as monotherapy alone. And for patients who are maybe opposed to injectable biologic agents, this may make some sense. There's a lot of direct-to-consumer advertising with all of these products. And really, this is under the purview of the rheumatologist to decide that. But again, with all of these agents, important to consider the risk and the benefit. How well is the patient doing? What's their functional status? How can we interrupt the progression of rheumatoid arthritis? And yet always be thinking when you see these patients, particularly if you're not the rheumatologist or on the rheumatology team, be keeping in mind that you are always concerned about their risk for infection. And so because we are concerned for their risk for infection, it's particularly important that we monitor them carefully and assess their status for anything of an infectious process. And when you see that and you look at their med reconciliation, see they're on one of these drugs, really important for us to take that seriously and recognize that the patient is immunosuppressed. Okay, let's go on to look at the pathophysiology of gout and then some of the treatment modalities for gout. Gout is a recurrent inflammatory disorder associated with elevated uric acid levels. In these cases, we often see urate crystals that deposit in tissues or in joints and promote inflammation. We typically think of the classic presentation is in the joints around the large toe, but it could be in other places as well. And one of the first things to think about is to look at what drug therapy a patient could be on that could affect the clearance of or the accumulation of elevated uric acid levels. And the diuretics, particularly the thiazide diuretics, are the most notorious here. Loop diuretics can also do it. Salicylates can do it. Cyclosporin and levodopa used in Parkinson's also have some potential risk, but the thiazide diuretics are probably the most notorious for causing elevated uric acid levels. Our classifications of gout, we look at acute gouty arthritis. We have an intercritical gout period of interval periods between attacks where they still may have elevated uric acid levels but are not symptomatic. And then they could have recurrent gout that is chronic. And then the severities we consider staging it, and we'll talk about it with a graphic in a minute, is whether or not it's mild, moderate, or severe, and that affects both how many joints are involved and whether or not it's stable or unstable in its status. We also look at the nature of the joints that are involved. And usually we think of the interphalangeal joints as the classic presentation, particularly in the toe. But you could have other joints that are affected as well, particularly in large and medium joints. The treatment goals in gout are to have no trophi. If they have no trophi, is that to get their uric acid levels below 6. If they do have deposits, then you want their uric acid levels below 5. And really, another goal is to decrease the frequency of their attacks. The other issues we think of with therapies we have are really to focus on both the reduction in inflammation and also the reduction in elevated uric acid levels. And the modalities we have first for inflammation are to use anti-inflammatories. And what is considered pretty routine to use is colchicine as the standard anti-inflammatory first-line agent. And colchicine is sort of the standard to use in gout. As an alternative, you could use any of the nonsteroidals. Indomethacin could be used. And, a third choice here might be a corticosteroid, prednisone, for example, could be a consideration to a patient who couldn't tolerate either a nonsteroidal or colchicine. And then the three common agents we think of for elevated uric acid levels are allopurinol, probenecid, and sulfentrazone. And so all of those are sort of part of your treatment options we have in treatment of gout. So let's first look at some of the non-pharmacologic treatments and approaches in gout. First of all, we want to look at lifestyle changes that if folks are obese, that's a corollary risk for gout. Their diet should be healthy, and you're going to worry about particularly foods that are high in purines. Organ meat, for example, is particularly high in purines, and so you want to look at folks maybe limiting their diet of that if they have elevated uric acid levels. There's also questions about whether gout is triggered by high fructose corn syrup or by elevated alcohol intake. And so those are all things that can look at as options to consider in your evaluation of someone who has gout. When we're categorizing gouty attacks, we look at their severity of gout by the number of, by their pain scores, by their duration of onset, and by the extent of how many joints are involved. So all of those are important variables to look at when someone has gout. When we consider colchicine, which has been on the market for many, many years, this is kind of the standard first-line anti-inflammatory drug that's specific really only for gout. And it really has its use in both treating an acute attack and in lower doses reducing a future attack or aborting an impending attack. Once an attack is in place, though, we often have to dose pretty heavily. But folks can get by who have repeated gouty attacks. In addition to managing the uric acid levels, we find that a lower dose of colchicine, renally adjusted, if they have renal dysfunction, could forestall the risk for a future attack. So that's important to consider. If somebody's having early symptoms of an impending attack, we need to use more dosing than the prophylaxis. And what's interesting is this old agent that's been around for years and years and years is there's no real sense, really, of how the drug really works as an anti-inflammatory. The pharmacokinetics of colchicine is absorbed orally pretty well. It's excreted. We can also look at indomethacin use. It's a nonsteroidal. It's probably one of the most important agents used for serious inflammatory states, but it's also associated with not only a great degree of suppression of inflammation, maybe more effective than most of the nonsteroidals, but it is really a drug that's associated with a risk for significant GI bleed, and so a concern for us if somebody has a history of GI bleeding risk. Okay, the first step really in someone with gout is to get their inflammation under control, and that's typically with the use of colchicine or indomethacin or another nonsteroidal. A second goal we'll have is to reduce uric acid levels, and the agent we use almost always here is allopurinol. It inhibits uric acid production by inhibition of xanthine oxidase. It's well absorbed orally. It is used as a drug of choice in folks who have gout or in hyperuricemia, but there's a caveat to when we use it. With allopurinol, we want to first make sure that we have good control of their acute inflammatory state before we start allopurinol. The reason for that is when you start allopurinol, that initial use of allopurinol, which it results in affecting uric acid production and increasing, inhibiting xanthine oxidase, may incidentally cause early on in the first day or two of therapy actually no reduction, in fact, maybe even an elevation in uric acid levels for a brief period of time. And so we wait to start the allopurinol until after the symptoms of the acute gouty attack have subsided just a little bit. The adverse effects of allopurinol generally well tolerated, but there is a very rare but serious potential for a hypersensitivity reaction that could occur. So if folks get a rash in allopurinol, we take that really pretty seriously. The drug interactions, there are a few that affect some of the drug metabolizing enzymes, but for a big situation, for the most part, that's not really a major concern. With allopurinol, it's available generically. There's lots of preparations that are there. It's typically dosed 300 milligrams a day for someone with normal renal function, and then we reduce the dose based on creatinine clearance estimates. And it's a pretty significant reduction in dose we make based on renal function. So allopurinol is one of those drugs that when we see patients on it as pharmacists, we're always looking at estimating their renal function and adjusting the dose downward if they have any degree of reduced creatinine clearance. An older agent that is sometimes used to manage uric acid levels as well as probenecid. This acts on the renal tubules to inhibit the reabsorption of uric acid. More often, probenecid historically has been used with a penicillin derivative For example, when you wanted elevated penicillin levels, for example, in the treatment of primary syphilis, we don't use it that much in its use in gout, but occasionally you will see it used. When it is used, it's pretty well tolerated as an agent. There's a few drug interactions, but we don't really see it used all that often. And finally, sulfampirazone, uricosuric agent as well in chronic gout is another alternative. I will tell you quite honestly, the agent we see almost always is allopurinol. There's also a new alternative to allopurinol we'll talk about in a minute, but I have to tell you honestly, I don't know that it really offers any significant advantage over the agent we know, which is allopurinol. So here's a table that looks at many of those agents and dosing regimens that are available and comments about its use. Colchicine, the nonsteroidals, or Celebrex, for example, when they are appropriate to use in gout. And then the oral corticosteroids do have a role. Typically, this is going to be used when folks have a reason not to use one of either colchicine or using indomethacin. That's typically when at least I've seen in practice, when someone will go with an oral corticosteroid. And then the urate lowering agents, really allopurinol is really the only important agent that I think clinically we see used. What I didn't mention here, and what there is some data to suggest that maybe it offers some benefit, is losartan. And here's the situation that might be a consideration. If you've got a patient for whom they have gout and you need an ACE or an ARB, or it makes sense to do that, perhaps losartan makes sense for them. And I think that most clinicians wouldn't necessarily go pull losartan out of their hat for treating gout, but particularly you have a patient who had gouty attack on a thiazide diuretic. Well, you're going to stop the thiazide, and if they needed it for blood pressure control and have a comorbidity like diabetes or heart failure, for which they're a candidate for an ACE or an ARB, bingo, losartan at least logically makes sense in that situation. A couple of the urate lowering agents, fenofibrate, used for patients who might have elevated triglyceride levels and secondarily effective for gout. Clinically, I don't think many clinicians would go with fenofibrate as an alternative. And finally, this last IV agent for severe gout, I have no experience with this agent, but I'd say this might be something that a rheumatologist may pull out of their hat. For patients who actually have a long-term risk for gout, we consider using agents as prophylaxis. And the primary agents that we'll look at for prophylaxis primarily are the first-line colchicine in low dose. It has to be dose adjusted, particularly in patients who have renal dysfunction. We could consider nonsteroidals. Our biggest risk with the nonsteroidals is the risk for GI bleeding and renal insufficiency. And so these are long-term risks associated with long-term NSAID use. And so as such, we prefer not doing that if we can help it. The use of long-term prednisone or corticosteroids, we really try to look at only in circumstances where there is an ongoing and significant risk for gout, and that the benefit of corticosteroids outweighs the risk. In that long-term corticosteroids are almost never a great option for us, given the complications associated with that therapy. As we look at approaching gout management, typically we look at severity, duration, and extent in part of how we choose which modalities to go with. So for mild to moderate disease and really only involving a joint or two, we typically look at just the use of colchicine or nonsteroidal or an oral corticosteroid. In more severe cases, or when joints are involved, multiple joints are involved, you may see the use of both either a nonsteroidal or an oral corticosteroid plus the use of colchicine as well. And that's in the acute phase. And in almost any of these cases, if the uric acid levels are elevated above 5 or 6, as we discussed earlier, we're also going to look at managing their hyperuricemia accordingly after the gouty attack is done, usually with allopurinol. All right, on to multiple sclerosis, autoimmune disorder, which affects the central nervous system, demyelinization. And whether we covered it here or we could also argue that this could be covered in neurology, but we put it here. Typically, the clinical course of MS is relapsing and remitting, and it can worsen over time, become progressive in its nature. So the clinical courses have all these different patterns, which make it very frustrating, clearly for patients, but also their families, their loved ones, and also frustrating for clinicians and management as well. The epidemiology, typically we diagnose this between the age of 20 and 50 years of age. More women than men officially develop it, but we see a lot of men who come in with MS or presentation as well. The acute treatment is usually managed with corticosteroids, often will be very aggressive at giving a gram of IV methylprednisolone as a single dose or repeated doses, and sometimes folks will come into the oncology clinic, for example, where they also, at the same place, they'll get infusion suites. It's not always just the oncology clinic. They come into an infusion suite and get a dose of IV methylprednisolone and maybe on more than one day as part of the management for an acute exacerbation of their MS. It's also possible to give oral, although because I work in hospital practice, I only see the IV used. And typically, whether or not we give a prednisone taper or not is variable. I don't have a lot of experience with this, but usually what I see is folks with severe disease coming in with for management with IV methylprednisolone, with some really large doses, typically a gram at least for one day, but sometimes 2, 3, even 4 days of a gram of methylpred therapy. The disease-modifying therapies are also used to some degree, and these are typically managed by either the neuro or the rheumatology teams. They typically, here we have Lemtrada, which binds to CD52 receptors and as such offers some benefit at suppressing or disease-modifying multiple sclerosis symptoms. Typically, the adverse effects associated with it are significant. Typically, you'll have folks who have thyroid problems associated with it, so you need to be kind of aware of that. A lot of patients with these therapies, monoclonal antibodies, will have infusion reactions, and that's very common with this agent. And in addition, because they're immunosuppressant, we worry about their risk for all kinds of infections. We worry about not only tuberculosis, hepatitis B, hepatitis C. You also worry about herpes zoster developing as well for them. So all important considerations. We also, because of the immunosuppressant nature, we worry about melanomas, we worry about lymphomas, particularly perhaps even thyroid cancer, and avoid live vaccines for use of this therapy as well. Other therapies we can see used are the beta interferons. These are older agents that have been around for a while with MS. When they are treated, early treatment is better. But keep in mind that the role of interferons is evolving and perhaps lessening than it was perhaps a decade or so ago. The depression is the most common adverse effect for interferons and is considered a contraindication to using interferons. In addition, you want to monitor for depression for patients. So you'll want to use like a Hamilton Depression Scale or some other sort of quantifiable assessment for folks around these therapies. You also look for symptoms that look or present like the flu or injection site reactions as well. Other disease, a couple of disease-modifying agents, and these really fall to the specialist domain. Tecfidera, which is an agent I don't have any experience with some skin flushing reactions, among other things. This is an antioxidant and perhaps cytoprotective, inhibiting the pro-inflammatory cytokines that are result in the inflammatory state. So this has some role in the management of MS. We also have, and these two agents I think I've seen more often in patients coming into the hospital with MS than any other, particularly Copaxone. Copaxone is an injectable form that patients can do at home. They do themselves. Typically what they're going to do is going to ice down their site and administer that. And then there's an oral agent for MS, really the only one, the first one that came on the market anyway, is Gilenya, which has been around for a few years now, and patients have to be monitored, interestingly, for bradycardias and heart blocks. So we want to make sure that's being done for folks on these agents. And these two are the ones I probably see patients coming in more on than most others, at least for disease-modifying therapy. A few other things that are listed here. Tysabri is probably another agent we'll see for relapsing forms of MS. We use it for other indications as well. And we'll see that used in the infusion suite pretty commonly. Mitoxantrone is really, I think, a second-line agent for more progressive forms of MS, and it's pretty limited on its use to my knowledge, but again, I'm not really an expert in MS modalities. Here's a couple of tables that list all of or most of the disease-modifying treatments for MS, so you can sort of go through these and sort of see they're really kind of specialty products. I think the one that I've seen folks come in more often than others are Copaxone, which is a daily or a 3-time-a-week subcutaneous injection that patients really need to ice their injection site, and injection site reactions are pretty common. Systemic reactions are also pretty common at 15%, but injection site reactions are almost universal with it. Some of the other modalities, as we listed here, the interferons are listed here, mitoxantrone also listed here. And one of the last sets here are the interferons, or Tysabri, as well, and you can see some dosing and adverse effect profile for these agents as well. As far as managing others' acute symptoms here, all right, and on to fibromyalgia. And fibromyalgia diagnosis is based almost purely on clinical findings, and really the first step is to validate with the patient who's presenting with fibromyalgia the reality of what they're experiencing. Don't throw a deaf ear to that. It's very real to them. And their experience is such that they have a lot of really discomfort. So the non-drug treatments ought to really be the first line approach with everybody. Stretching, exercise, massage, heat, stress management. And so things like yoga might be a really important consideration for the addition for someone with fibromyalgia. And also a modest exercise, heat therapy, stretching, massage therapy, all as modalities that improve the discomfort associated with patients with fibromyalgia. And then the drug therapies that are involved, typically the three that we'll see used most often, the one that's direct-to-consumer advertised is Lyrica or pregabalin, which is a Schedule IV drug. It's a GABA analog. It's probably, while they don't officially have an FDA approval, gabapentin as a analog is available generically and probably has similar outcomes with its use. Gabapentin is not a controlled drug as of this minute I'm recording this, but we've been waiting a couple of years for gabapentin to also have a Schedule IV DEA category, probably attached to it over the next year or two. Duloxetine or Cymbalta as a serotonin and norepinephrine reuptake inhibitor. We think of it as an agent mostly for depression, but in fact there's good data for its use as an analgesic, particularly in the pattern of neuronal nerve fiber pain that fibromyalgia is believed to be. And so Cymbalta, in my mind, Cymbalta makes more sense than Lyrica does as a first-line therapy for a lot of patients, particularly if there's a comorbid question of a depressive component for this patient. But even if there's not, Cymbalta is really good for as a good modality. It's a not controlled substance for this type of situation, and I think a lot of clinicians are considering Cymbalta as a reasonable alternative here. And then Savella, sort of like Cymbalta, is an alternative here. Again, another serotonin norepinephrine reuptake inhibitor. Finally, non-FDA approved is whether or not there's a role for tricyclic antidepressants at bedtime. We use tricyclic antidepressants for neuropathic pain. This is a neuropathic type pain syndrome, so that may make sense. But you worry about anybody with concurrent depression, even though it's antidepressant, you worry about suicidal ideation and the risk for overdose, which can be fatal. So you want to be careful about that. And also, whether or not there's a role for skeletal muscle relaxants, I will tell you most often what I hear clinicians say is to avoid skeletal muscle relaxants if we all can, particularly chronically, because they really probably don't do a lot really for benefit. And then yet it's another somewhat sedating group of agents that patients it ends up like a polypharmacy soup that patients end up with without a clear guideline that it's offering benefit for patients. And so I think that most clinicians probably would consider avoiding a skeletal muscle relaxant. So let's talk about a couple of agents here. Gabapentin we've already talked about in neurology, or we've talked about in pain management, or we will talk about in pain management and neurology. I don't know if we've gotten to that yet. So important to consider that as an agent, also an alternative to pregabalin or Lyrica. The advantage this has is it's inexpensive. It's generically available, widely used, and you will probably become quite familiar with Neurontin in pain syndromes, particularly as it relates to neuropathic pain. And so it can be used, and it's pretty commonly used for patients with fibromyalgia. It has to be dose adjusted in renal dysfunction, and likely going to be a Schedule IV drug in the future. Pregabalin or Lyrica, consider it really quite like gabapentin. It is a Schedule IV drug. It's associated like with gabapentin, sedation, memory impairment, and there is a potential risk here, much lower than with ACE inhibitors, but a potential for angioedema. So you want to keep that at least as an awareness for that. All right, one of the last sets of topics we're going to do before we get into the discussion of infections related to this block is osteoporosis, osteopenias. And the World Health Organization has definitions based on T-scores and the standard deviations away from the mean for what you would expect. And osteopenias, where bone mineral density is between 1 and 2.5 standard deviations below the young adult mean, and osteoporosis more than 2.5 standard deviations below the adult mean. Risk factors for osteoporotic fractures, there are many of them. Certainly women are at much higher risk than men. White race or Asian, Southeast Asian populations as well. Or in Japan, I think osteoporosis risks are considered high. Nutritional status, particularly as it relates to long-term low-calorie intake, is an issue. You also want to look at women who are early menopause as that relates to bone density and estrogen changes, estrogen deficiency. Glucocorticoids are notorious for causing osteoporotic fracture risks in men and women. Other drugs that can be osteoporotic are long-term heparin or Lovenox and oxyparin. Anticonvulsants can do that. We also see other drugs that are associated with listed here. Also, patients who have very low body mass or low weight, family histories of osteoporosis, poor vitamin D and calcium intake throughout their life, if they have no exercise, smoking, alcoholism, all correlated with osteoporotic fracture risks. Dementia, interestingly impaired eyesight, and previous fractures or history of falls all pose risk for fractures. The other concern here is the recommendations to reduce risks for osteoporosis. And we were much more aggressive at aggressively managing osteoporosis perhaps a decade ago than we seem to be now, partly because what used to be the standard modalities have risks associated with them that came to play or we became much more aware of after we had millions of women and men on these therapies. So the first thing you want to do is to redo the non-drug things. Avoid smoking, moderate alcohol, weight-bearing exercise, muscle strengthening exercise, making sure adequate calcium and vitamin D without overdoing it, and then looking at the appropriate assessments for a patient to sort of stratify where they are in their risk category. The other issues you want to make sure is that if there's a falls risk for a patient, you're doing all the things to prevent a falls risk. So orthostatic hypotension assessments if a patient is, particularly if they're on agents that lower blood pressure, you want to be aware of that. You also want to look at all the other concerns you've got for patients who could fall for multiple reasons: sedative status, vision status, risk for delirium or something like that. The recommended bone mineral density testing is listed here based on who should get them: women over the age of 65, men age 50 to 70 if they've had a fracture, postmenopausal women who have medical causes for their bone loss, or there's then a subset of other factors here as well. And then the initiation of drug therapy typically is considered now when patients have had a fracture, either hip or spine, or their bone density is below 2.5 standard deviations below the T-score, below the mean at the spine, the hip, or the femoral neck. And then for those folks who have a bone density score that's less, is not quite as significant as 2.5 or more standard deviations below the mean, then you kind of look at their long-term risk for fractures and weigh that accordingly, and then consider bone density assessments every couple of years. We would have, a few years ago, been more likely to institute pretty aggressive therapy in folks who don't have so low bone density scores, but because the therapies are a little less mainline now because of some adverse effects risks, which we'll talk about in a minute, we really limit those to folks who've either had a fracture or are at much higher risk based on their T-score. So the lifestyle modifications, again, as we alluded to: weight-bearing exercise, smoking cessation, limiting alcohol intake, and reducing falls risk are the four sort of pivotal foundational things we do for every patient at risk for osteoporosis. We then can look at the biphosphonates, and the biphosphonates have been used pretty aggressively for a couple of decades, and really over the last 5 or 6 years are becoming a little more hesitant because of some adverse effects, including GI effects, and what really people are concerned about are atypical fractures that are associated with folks on these drugs, which seem counterintuitive but can happen. And basically what these biphosphonates do is, by affecting the normal and abnormal bone resorption, inhibiting it, the bone resorption, you may see a subtle difference in the nature of the architecture of mineral deposit in the bone. And that change in that architecture may be just enough that a fall could still cause a fracture even though the density is improved. The architecture of that mineralization in the bone doesn't happen with enough cross-hatching, or whatever you want to call it, that may offer the reduced fracture risk. So they do reduce fractures in general, but we see these atypical fractures happen, and so that's got folks a little concerned about how we use these agents. The other concern is the osteonecrosis of the jaw, particularly folks who have pre-existing dental problems, is a real concern and has been a problem associated with bisphosphonates. So this has kind of had folks be a little hesitant about routinely using bisphosphonates now, compared to where we stood maybe a decade or so ago. There are also significant interactions with these biphosphonates. So typically when folks take them, they need to take them upright. Usually the regimens are once a week or once a month if they're oral therapies. And we look at those, and folks take it upright with a glass of water, and they stay upright for an hour or so. There's also a couple of varying regimens that are there depending on the agent, and there's actually therapies now that are once a month regimens that are really easier for patients to adhere to. Some of the dosings listed here and some of the regimens are listed here. In addition to the oral therapies that can be, Abandronate, for example, is more common once a month regimen now that will increase bone mineralization with its use. Zoledronic acid is probably the agent that's used as an IV formulation once a year to reduce fracture risk, but you need to adjust dosing for renal dysfunction. There are infusion reactions that have occurred, and these are really folks who have significant osteoporosis, not really first-line therapies for folks who have moderate bone mineral density. And then we have, so here's a table that has the list of the biphosphonates. They'll talk about all the different regimens in the right-hand column for each of these agents, and then what some of the indications are for in the middle column. And encourage you to sort of review that. What's the role of calcium and vitamin D? Typically, you want to make sure that folks get adequate calcium. You don't want to overdo it. High doses, more than 2 grams of calcium a day, can increase risk for constipation. They can increase risk for kidney stones. They can affect the absorption of iron or zinc, and they can have other comorbidity problems for certain patients as well. So we're careful about that. And we also want to make sure that the vitamin D is adequate for patients, but we don't want to overdo it because it's a fat-soluble vitamin that can accumulate. Many clinicians, particularly who work with patients in areas that don't get as much daylight, particularly in the winter months, so folks in the northern hemisphere, typically who are in climates, particularly expect to see it in, for example, in Canada or in the northern United States. Those folks may be vitamin D deficient, and many times, particularly if there's a concurrent risk for depression or something else, we'll often get vitamin D levels at least every so often on a patient and consider supplemental vitamin D. But that has also the added benefit of supplementing vitamin D for patients with osteoporosis risk as well. The selective estrogen receptor modulators like Estiva, Raloxifene, historically was used. We don't use estrogens really primarily for osteoporosis anymore. And the estrogen receptor modulators also not routinely used for women with osteoporosis. I have a benefit there for osteoporosis, but the thromboembolic risks associated with any of the estrogen products and make these agents less advantageous to use, probably riskier than the benefit could be. So the estrogen receptor modulators, as we alluded to, all the adverse effects. The biggest one I really worry about clinically is about venous thromboembolic event risk, which is 2 to 3 times increased over placebo. Absolutely much higher risk in patients who smoke. And so all of these are considered really probably riskier than most clinicians would want to tolerate for management of osteoporosis. The estrogen, conjugate estrogens themselves also can be used for osteoporosis, but usually they're limited to patients who have either severe disease, very severe disease, women who have severe disease, and usually also for the management of severe postmenopausal vasomotor symptoms. And again, many clinicians would look at, as we talked about in women's health section, of limiting estrogen therapy for as short a duration as possible. And because we're treating osteoporosis, which will be a lifelong issue, then there's debate about what's the risk and the benefit of an estrogen product that's administered over years. So clinicians would typically look at being careful or avoiding this. Another agent that's a consideration is calcitonin, and calcitonin inhibits bone resorption. It's indicated for osteoporosis in postmenopausal women. It's not considered a first line, but it is a therapy to consider. It's available nasally as well as in an injectable form as well. And so it's an option that patients could conceivably have. One advantage that calcitonin has is if folks have osteoporosis with significant bone pain, particularly spinal bone pain, sometimes this actually improves bone pain as well. And so sometimes that seems to be a niche associated with calcitonin use. And then a couple of other options here. Forteo is a recombinant human parathyroid hormone. It's really reserved for folks with very low bone density, usually T-scores less than 3. It's usually, in my mind, usually limited to an endocrinologist use or an orthopedic specialist's use, and not really a first-line agent at all. It has some limits in its use because of risks for patients who have bone mets and cancers or other tumors that would be potentially need to get ruled out. So it's really pretty limited. It's also a once-a-day subcutaneous injection. That's also quite expensive, and so really not at all first-line therapy. And then what was approved almost a decade ago for postmenopausal women with bone loss is Prolia. And it's a osteoclast. It inhibits osteoclastic-mediated bone resorption. It is a monoclonal antibody directed against the receptor activator of a nuclear factor ligand, and it is a cytokine which is essential for a survival of osteoclasts. And so it really is a simple agent to administer subcutaneously once every 6 months. Its efficacy is reasonable. The safety issues are probably not overly problematic, but we worry about possible opportunistic infections and or hypocalcemia. And because of these risks, the FDA has designated this as a REMS drug, and so we'll look at that as well. So encapsulating all of the treatments for osteoporosis, we typically will find that a lot of patients will have a limited approach for what drugs we can use in the management of osteoporosis.
Here is a summary slide from 2021-2022 about postmenopausal osteoporosis treatment approaches. And in this case, I think, first of all, we're thinking about a postmenopausal woman who has risks for fractures. In the top portion of this table, it would be considered a patient who's high risk but with no prior fractures. And there are a number of first-line agents here, but probably alendronate would be considered, or bisphosphonate, a first-line option in most of these patients. Short of that, maybe denosumab or Prolia or one of these other agents might be appropriate as well. And then as you read across the table in summary, there are some alternative first lines and then considerations over time of what you need to do if there continue to be no fractures, or if there continues to be bone loss, or if there are a risk for more fractures. The lower portion of the table looks at very high-risk patients who have had prior fractures. And in these patients, the bisphosphonates classically have a more of a second-line role for the most part, and really looking at the more aggressive regimens here. This and the guidelines that are available in different professional societies over time sort of may move these recommendations around a bit. I think what the limited experience I've had in managing this kind of issue, it's a function of what the patient wants, what the goals of therapy are for the patient. And while you're looking at doing everything you can to improve bone density and reduce fracture risk for these patients, you're doing things beyond just the drug therapy. Important to look at making sure adequate, reasonable weight-bearing exercise that's appropriate for that patient is being done, as well as calcium and vitamin D supplementation that is adequate. And on top of all of that, everything you can do for falls reduction risk as well should be done. So you're looking at orthostatic blood pressures, you're reassessing their entire medication list for the risk for falls as part of that holistic approach for how we manage postmenopausal osteoporosis.
Finally, let's look at some of our discussion we've had already about managing bone-related infections. One is diabetic foot, which we spoke about, that can migrate and eventually become osteomyelitis. And so diabetic foot infections we talked about, typically the etiologies, they're often polymicrobial, and so we need broad spectrum therapy typically. We talked about the prevention of diabetic foot ulcers, both in general infection disease and also in diabetes, so I won't reiterate that here. But the big issues we think about are all of the other options we can use. In addition to IV therapy and oral antibiotic therapy, there's also the topical Regranex we briefly talked about that may have some role in diabetic foot as well. And then finally, osteomyelitis, infection in the bone, we also talked about earlier in the curriculum. We look at radiologically testing for this. Typically, you're also going to have, in the case of osteomyelitis, probably a surgical consult in place as well if you need to isolate any kind of cultures and get an assessment in wound debridement as well for a patient with osteo. The differentiation between hematogenous spread, contiguous spread, and vascular insufficiency as etiologies are listed in this slide, and you've seen this before in the curriculum. The empiric treatment typically depends on how old a patient is. In pediatrics, our osteomyelitis issues look at differing agents, typically nafcillin plus an aminoglycoside or nafcillin plus cefotaxime. In newborns, we look at nafcillin plus cefotaxime in infants, and that could be also nafcillin in pediatrics. But you're going to look at blood cultures to rule out MRSA, and if MRSA is there, typically we're going to look at adding vancomycin or linezolid or some other MRSA modality. The other things we'll think about typically in managing osteomyelitis is its duration of therapy. We are going to go at least 6 weeks of IV therapy for osteo, and in chronic osteo, they usually need 6 to 8 weeks of IV therapy, maybe even up to 12 weeks of IV therapy, and then may continue on oral therapy for the remaining year. Typically, that's done in guidance with both the osteo team and the infectious disease service team. Okay, finally, the drugs we expect you to have some familiarity with related to dosing. These are pretty common used agents.